Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. Thank you very much to Indonesian Gynecological Endoscopy Society, IGES, for inviting me to give a talk in this very beautiful meeting. First of all, I'd like to apologize that I cannot attend in person in Solo because I have another meetings in Palembang. So I'd like to continue our discussion today with the topics breaking the barriers, the role of laparoscopic in improving ART success. We know that in early history, that the basics of minimally invasive surgery is for reducing surgical trauma and improving recovery. So that's why laparoscopic surgery become integral in gynecological practice. With over 100 years, continuous innovations with early limitations starting from poor illumination and visualizations that become main foundation for modern endoscopic surgery. We know all that history of laparoscopic surgery starting from diagnostic era and operative era with Professor Kurt Sam from Germany. He did the first laparoscopic appendectomy beginning the minimal invasive revolution across the globe. You can see here how in the era of operative laparoscopic surgery, the starting from 1980 when appendectomy and afterward cholecystectomy and also hysterectomy were done by laparoscopic surgery. The expansion of laparoscopic into gynecological fields, I think, was applicable, expanded to manage ectopic pregnancy, tubal sterilization and reconstructions, myomectomy, hysterectomy, laparoscopic on endometrioma, and also at the dialysis, with the goals and benefits is shorter stay, lesser pain, and faster recovery. And we know at the moment, many modern laparoscopic surgery development, including robot-assisted systems, high definition, 4D, single port, and Phenol technique. How the role of reproductive surgery in modern fertility management? We know that before IVF, surgery was the cornerstone of fertility care, and after IVF was founded in 1978, there's a reducing of surgical use, particularly in fertility management. By the time laparoscopic performed with other surgical procedures, as mentioned in previous slide, including myomectomy, endometriosis, adenomyosis, ovarian and tubal surgery, and also including Mullerian anomalies that will help to reduce miscarriage and solving the problem in infertility case. If you look these tables, how the laparotomy to laparoscopy and to IVF era, how was the development? The first era is laparotomy, dominant in early 20th century, large abdominal incision for both diagnostic and therapeutic procedures with prolonged recovery. And then the second era is laparoscopic in infertility, starting from diagnostic laparoscopy, visualized tubes, ovaries, endometriosis, and also operative laparoscopic for managing endometriosis, adhesion, ectopic pregnancy, and an improved success rate before IVF era, bridging between surgical and operative medicines. And then the third era is IVF, starting from 1978, whenever Louis Brown was born in UK as a first IVF test tube baby. See from purely surgical corrections to laboratory fertilizations, laparoscopic facilitated egg retrieval, and also embryo transfers in the first IVF cycles done by Patrick Steptoe and Robert Edward. At that time, Patrick Steptoe was also the first human that see the tube, ovarian, tubal, and also ovary and uterus by doing laparoscopic surgery. This is the era of integration of surgery and reproductive endocrinology. How was the origin and evolution of reproductive surgery? Reproductive surgery has transitioned from the primary treatment for infertility to an essential adjuvant therapy in modern fertility management. Fertility-sparing surgery, like myomectomy, tubal surgery, were early form of reproductive surgery, and ART shifted focus away from surgical intervention. Recent data highlights the benefit of surgical correction of reproductive pathologies, renewing interest in reproductive surgery, new techniques, and instrumentation enhancing the role of reproductive surgeons on fertility preservation. If we look the data, how salpingectomy before assisted reproductive technology and its role toward the result of IVF. We know that hydrosalpinx negatively affect IVF outcome, including implantation failure, miscarriage, ectopic pregnancy. But each IVF success improves when hydrosalpinx is treated surgically through salpingectomy before IVF. The presence of tubal disease, surgical approach based on unilateral salpingectomy compared to bilateral salpingectomy may be considered relatively safer toward ovarian disease markers, ovarian response, and ovarian stimulation protocols. If we look laparoscopic unilateral salpingectomy, they have more benefits compared to ovarian reserve, ovarian response, implantations, and also safety conclusion if we compare with laparoscopic bilateral salpingectomy. The unilateral salpingectomy gives the result better than bilateral salpingectomy. There is a significant increase on ongoing pregnancy rate among women treated salpingectomy or ultrasound-guided aspirations compared to those managed expectantly. Salpingectomy and laparoscopic tubal occlusion were associated with higher clinical pregnancy rate than no treatment. Direct comparison suggested a slight advantage of laparoscopic tubal occlusions over ultrasound-guided aspiration for improving clinical pregnancy rate. If we look this picture, the salpingectomy show a non-significant positive trends, even at ratio 1.82 compared versus no treatment. Salpingectomy markedly increased ongoing pregnancy rate versus no treatment with odds ratio 4.3, and laparoscopic tubal occlusion show a non-significant positive trend with odds ratio 3.05. Both laparoscopic techniques significantly improve clinical pregnancy, with laparoscopic tubal occlusion slightly outperforming salpingectomy in a network comparison. Salpingectomy, they have odds ratio 2.24 versus no treatment, and tubal occlusion, they have odds ratio 2.55 versus no treatment, with confidence interval below, more than above 1. So this is clinically significant. How was the impact of opportunistic salpingectomy on ovarian reserve? If we look, the studies were assessing the effect of salpingectomy on ovarian response during ART cycles, noted that increased gonadotropin requirement and lower fertilization rate in women who underwent salpingectomy. It means there's indication that lower AMH level and FC in patients with history of salpingectomy, suggesting a potential compromise in ovarian reserve after salpingectomy. This table compared the fertility preserving laparoscopic surgery and ART pregnancy. This is the case in major tubal disease. ART, I think, giving ART procedures produce a better result with a pregnancy rate in major tubal disease around up to 28% compared to 5% the patient who underwent laparoscopic surgery. And in advanced endometriosis as well, they have a better result, 26%. Compared to 16% in patient underwent laparoscopic surgery. This is our data in Jakarta, how we compare the serum AMH and leaf expressions after laparoscopic salpingectomy, both in unilateral and bilateral salpingectomy. This is the data baseline characteristic, the age of patient 31 years old, and then serum AMH 4.19 nanogram per milliliter, If you look, the table of anti-follicle count is not significantly different before and after laparoscopic surgery, and also serum M8 is not significantly different before and after laparoscopic surgery, after salpingectomy, and also serum leukemic inhibitory factors in endometrium, which is the one of the endometrial receptive marker, is not significantly different even after salpingectomy. Expression of leaf increase, but not significantly different. We also compared between unilateral and bilateral salpingectomy. There is no difference of expression of leaf in the endometrium before and after salpingectomy. So salpingectomy looks is still very safe. If we did salpingectomy, very standard, and then with very good competency, it will increasing and improving IVF after salpingectomy, particularly in the bilateral hydrosalping patients cases. The next is when and how is surgery required for large endometrioma prior to IVF. This is the survey of practices. So the management of large endometrioma before IVF involving balancing between benefit of surgery with the potential risk over and reserve. The survey highlights significant variability in current practice, influenced by practitioner expertise and also training rather than institutional settings. If you look this one, most likely they prefer to underwent laparoscopic cystectomy and then followed by others, include such as the using of plasma energy, laser, cyst drainage, and a combination cystectomy and ablations using carbon dioxide laser, plasma energy, using alcohol sclerotherapy, and others. And surgery mainly for a cyst more than 5 centimeters or when interfering with oocyte retrieval were done by the surgeon. So management of endometrioma before IVF in the large endometrioma may lower oocyte yield and response to stimulation. Surgery carries risk of removing healthy ovarian tissue. Surgical practice patterns, median threshold size for surgery is about 5 centimeters, and the most common technique laparoscopic cystectomy compared to others, and most likely they give perioperative hormonal treatment. Most of them give progestin hormonal therapy, and median timing of range rate for IVF after surgery is about approximately 6 weeks. If you look at the table comparison, this is endometrioma with ethanol sclerotherapy, and this is the underwent cystectomy. We looked at baseline anti-follicles was lowest in the patient underwent cystectomy in the big endometrioma. And also the serum estradiol is lowest in the patient underwent cystectomy compared the patient with endometrioma, and then also compare the patient underwent sclerotherapy with ethanol. So the risk of laparoscopy, there's a possible loss of ovarian tissue, reduced reserve that we can see by declining of serum MH, surgical trauma or adhesion formations, and recurrence risk after cystectomy. If you look the outcome of IVF, the pregnancy per embryo transfer was highest in the group with ethanol sclerotherapy compared with the myoma and compared with the cystectomy group. And then the cumulative live birth rate, the highest is coming from the patient underwent sclerotherapy with ethanol, followed by the endometrioma, and the lowest is the patient underwent cystectomy. So that's why we should be very careful when we decided to perform cystectomy in the patient with large endometrioma, particularly with bilateral endometrioma. And then how the impact of surgery for endometriosis on the outcome of IVF? For the superficial peritoneal endometriosis, the surgical excision of minimal mild endometriosis before IVF may slightly improve implantations, pregnancy, and also live birth rates. For the deep endometriosis, some studies show higher pregnancy and live birth rates when surgery preceding IVF, with odds ratio for pregnancy approximately between 1.8 to 2.2. However, other report no significant improvement and highlight surgical risks, including urethral damage, bowel leak, delayed IVF. So that's why surgery is not first line for asymptomatic patients with deeply infiltrating endometriosis. For ovarian endometriosis or endometrioma, it's clear that several studies report significant decline in serum image level after cystectomy, with an average reduction approximately 38% following unilateral excision and up to 44% after bilateral procedure. So that's why surgery should not be routinely recommended before IVF. That solely to enhance fertility outcomes, especially when the access of egg retrieval was prohibited by endometrioma. This is the randomized control trial to see how the new technique for laparoscopic management of ovarian endometriosis for preventing recurrence and also keeping ovarian reserve. If you look for surgery cell effectively reduce or recurrence rate of endometrioma and preserve ovarian reserve, especially when used during laparoscopic drainage. Surgical offers promising alternative to traditional cystectomy, particularly for patients with compromised ovarian reserve. Even further long studies are needed to confirm the result. If you look this table and this graph, we can see the recurrent and long-term complications. The recurrency rate after conventional cystectomy up to 27% within 24 months. With surgical assisted surgery, recurrency rate reduced only between 9 to 11% within 24 months. So we can see here, this is cystectomy and surgical is lowest in the recurrency rate and long-term complication compared to cystectomy alone. The other reproductive case also fibroid. How uterine fibroid affect 80% of women by age 50 and making it one of the major infertility causes. Minimal invasive myomectomy technique, including laparoscopic surgery, single port, robotic assisted, and also ultrasound guided HIFU, which could improve fertility outcome with less trauma compared to traditional open myomectomy. If you look this one, the faster recovery pregnancy rate is achieved by laparoscopic, 50 to 60%, and then single port, minimal incision, pregnancy rate up to 75% with shorter time to conception, only 7.6 months. And then robotic assisted laparoscopic myomectomy also safe, no uterine rupture. However, it is costly compared to others. And ultrasound guided HIFU, shorter conception time, but increasing the risk of preterm birth. How the result from laparotomy to laparoscopy to IVF? Initially used for diagnosis, laparoscopy evolved to surgical access route for treating infertility. Laparoscopic procedure reducing recovery time, hospitals say. The use of high-definition camera, improving visibility and teamwork during surgery. It plays a key role for improving outcome of ART. Innovation of technology, including 3D and robotic laparoscopy, improving visualization, and also the dexterity, the skill of surgeon during surgery. Support intraoperative decision-making by using AI, by using mini laparoscopy single port, using trauma and recovery time, and future focus combining laparoscopic intervention with personalized IVF protocols. So the goal for overcoming remaining barriers in fertility treatment through minimally invasive and technology-enhanced reproductive surgery. How restorative reproductive medicine will revitalizing reproductive health. This is innovation, then future frontier in restorative medicine. Even assisted reproductive technology have advanced outcomes. Still many couples fail to conceive due unaddressed pelvic, uterine, or systemic factors. For example, this IVF outcome uterine safety with and without surgical removal. After septum removal, the clinical pregnancy and live birth rate increasing up to 65%. It is because of minimal invasive surgery. Also in salpingectomy, we can see the pre and then post-surgery, both live birth and implantation rate increasing significantly. And then if you look comparative success rate for restorative medicine intervention versus ART, versus RRM alone, versus ART alone, versus combined RRM plus ART. This is RRM alone, average cost 2,000 up to 5,000, time to outcomes 3 to 6 months for surgery with live birth up to 60%. Directed to IVF is costly, with the live birth rate is up to 40%, but with combination, it will higher success rate up to 70%, with a slightly costly be up to 12,000 to 20,000 US dollars, and then time to outcome 6 to 12 months. If we compare cost effectiveness analysis, restorative reproductive medicine versus ART alone, this is the focus of fixed root cause, for example, fibroid resections. If we compare to restorative reproductive medicine, typical cost is between 2 to 5,000. We bypass to IVF, then 10 to 15,000 for IVF cycles. Time to conception, of course, IVF is faster, but we can see that the success rate is lower compared to restorative reproductive medicine. The success rate is better. So in some cases, we need to evaluate program. We need to evaluate to do intervention with restorative reproductive medicine. The intervention can be also lifestyle and also surgery and also the treatment such as drugs. And then evaluate progress. If there is no, the progress may be integrated with ART, then personalized protocols, and then we can outcome monitoring. We can see the pregnancy tracking and are there some issue. And then also if there is no improvement in the progress, we can do also continue restorative reproductive medicine by doing surgery. For example, a submucous fibroid and a endometrial polyp or septum, correcting this fire hysteroscopic procedure with increasing pregnancy rate in both spontaneous and also ART. And then restorative reproductive medicine can reduce the number of ART cycles needed, lowering financial and emotional burden. However, for advanced maternal age and severe malfactor, direct IVF may be the priority. Reproductive surgery remains a core component for infertility management. Will be complementing ART rather than replacing. The future of reproductive care lies in integration of surgery and ART to optimize fertility outcomes. Laparoscopy continue to evolve as minimally invasive, including fertility preserving technique. Personalized treatment planning, surgical decision guided by patient-specific factors, age, ovarian reserve, and fertility goal are important determining factors. Collaborative care, close partnership between reproductive surgeon and ART specialists for comprehensive fertility management. Training and expertise, sustaining dedicated program to preserve surgical skills and reproductive anatomy knowledge. Technology and advancement, incorporation of robotics, 3D visualization, and AI to improve surgical precision and safety. I come to my last slide for the take-home messages. Number one, reproductive surgery remains vital in the modern fertility management, but it should integrate with ART for optimal result. Laparoscopic technique play a crucial role in ART by optimizing pelvic condition, yet their use should be individualized, aiming to improving fertility outcome while preserving ovarian reserve and minimizing surgical risk. Laparoscopy and new hemostatic agent like Surgicel significantly reduce recurrent and improve reproductive outcome in ART procedures, especially in endometrioma cases. Laparoscopic cystectomy was performed when endometrioma size or symptoms could compromise IVF access or oocyte yield. Surgery was selective, not routine, reserved for cases where potential benefit outweighed ovarian reserve loss. And the last, restorative reproductive medicine, including laparoscopic surgery, can reduce the number of ART cycles needed, thus lowering financial and emotional burden. So we complement each other. Laparoscopic surgery and IVF complementary each other. Thank you very much for your kind attention. Very good morning. Wassalamualaikum warahmatullahi wabarakatuh.